Hi, my name is Grant Woodruff. I am a PGY3 General Surgery resident at the University of Florida College of Medicine in Jacksonville, Florida. I am presenting Patterns and Outcomes of Recurrent Traumatic Injury in Children at a Level 1 Pediatric Trauma Center. Traumatic injury is the leading cause of death in children ages 1 to 17 years. There have been studies which have demonstrated that up to 25% of children suspected to have experienced non-accidental trauma will have a recurrent traumatic event within 1 calendar year. While there are various injury prevention programs to help decrease the incidence of traumatic injury within the pediatric population, there is little information to identify those children at risk for recurrent injuries. So, it was our goal to determine the incidence of recurrent traumatic injury defined by repeated visits to our Level 1 Pediatric Trauma Center or Emergency Department to help correlate any patient-related demographics, injury characteristics, and patient-related outcomes. This study was a retrospective chart review from 2002 to 2016. We identified all children aged 0 to 17 years who were admitted to the hospital from our trauma center or emergency department 2 or more times subsequent to an initial injury. We abstracted patient demographics, socioeconomic variables, and clinical and institutional characteristics and compared them to our overall pediatric population. We used univariate and bivariate statistics where appropriate. And these were our results. 85 children met inclusion criteria for recurrent traumatic injury. Our recurrence rate for traumatic re-injury was found to be lower than expected at 1.6%. The mean age for recurrent injury was 12.4 years, with a male predominance of 70.6%. We identified a fairly injured population with mean injury severity scores of 14.9, with most injury patterns for re-injury stemming from either firearm or assault-related injuries. When compared to the overall pediatric population, the re-injured child tended to be older and more likely to be male. Again, 70.6% for the re-injured and 65% for our overall pediatric population. The re-injured population was also much more likely to be involved with violent injury-related mechanisms, such as firearm or assault-related injury patterns. These higher mechanism injury patterns would explain the elevated injury severity scores seen with the re-injured population when you compare them to the non-re-injured overall pediatric population. As a result, hospital lengths of stay were also longer in the re-injured population, 12.9 days versus 2.9 in the overall pediatric population. And upon discharge, the re-injured child would more likely require greater needs, whereas a greater percentage of our re-injured population would require rehab upon discharge. Traumatic injury still remains one of the leading causes of death in the pediatric population. Various prevention strategies do exist to help decrease the incidence of traumatic injury, but there is little information that help to identify those children at risk for re-injury in the traumatic population. We found a lower than expected re-injury rate. This could be accounted for by not following those children in the study who revisited our trauma center or emergency department when they were over the age of 18. There was also no way of tracking those children who visited the multiple other hospital systems within our area. Despite these limitations, when comparing children involved in traumatic injury versus those involved with re-injury still revealed some differences. The re-injured child tended to be older and more likely to be male. The re-injured patient was also more likely to be involved with more violent related injury mechanisms, such as firearms or assault-related injuries. They had higher injury severity scores with noted longer hospital lengths of stay. There was also greater discharge needs for those children who required rehab upon discharge. By identifying those higher risk injury mechanisms and individual risk factors for traumatic re-injury, we can help inform new targeted injury prevention strategies to help prevent those at risk for recurrent traumatic injury. These are my references. And thank you for listening. Please feel free to contact me with my email below with any questions or concerns.